Good morning, good afternoon, and good evening, and welcome to this webinar that is jointly organized by the WHO, World Health Organization, ISQua, International Society for Quality in Healthcare, and the BMJ. Today, we will discuss a topic around measurement and quality of care for the purpose of improving care. And we will go more in depth in relation to opportunities and challenges as they relate to implementation. Next slide, please. For today's panel, I am very privileged to introduce my co-organizers and all the panelists who will cover the topic today, starting with Elaine O'Connor, Head of Strategic Partnerships in ISQua, Emma Veitch, Collections Editor in the BMJ, Kathleen Hill, Senior Principal Technical Advisor in Jhpiego, Sogiteti, Vice President, Global Delivery in the Institute for Healthcare Improvement, and Dr. Reham Hassan, Improvement Advisor in the Hamad Healthcare Quality Institute, Qatar. With this, I would like to hand it over to Elaine O'Connor. Elaine, over to you.
Great. Thank you very much, Blerta. So thank you. So for those of you maybe not familiar with ISQua, we are a not-for-profit, members-based organization and community that is dedicated to improving quality in healthcare. Our mission is to inspire and drive improvement in health and the safety and quality of healthcare worldwide. And we do this in a number of ways by disseminating knowledge and information on quality improvement. And we do this via our annual conference, which is one of the world's leading conferences in quality and patient safety, and our journal, the International Journal for Quality in Healthcare. And you might see from my slide here that our conference, our 2024 conference, will take place later this year in Istanbul in Turkey. And we also disseminate knowledge through our online education program, our fellowship program, which is an online continuous professional development program in quality and safety for health and quality professionals. And we currently have over 2,000 fellows in over 70 countries across the world. And I'm sure that many of our fellows are actually joining us on our webinar here today. And ISQua itself is also an organization that is in official relations with the World Health Organization. And so we work very closely with Dr. Blerta and the team, the quality of care team in the Integrated Health Services Department in the WHO to support them in their work. And it was in this capacity, supporting the WHO with their work on national quality policy and strategies, that we first partnered with them over 2 years ago to host our first webinar, which was on country experiences of developing and implementing national quality policies and strategies. And since then, we have partnered together to host a number of webinars, all focusing on different aspects of quality of care and quality improvement in healthcare. And we are delighted to be here today to kick off the 2024 webinar series, which is focusing on the very important topic of measuring quality of care for the purpose of improving care. And we're also pleased to work with the BMJ, Jhpiego, and the IHI on today's webinar. And we're also actually pleased to say that one of our speakers on today's webinar, Sogiteti, is actually a member of our ISQua board. So I hope that you all enjoy today's webinar. And I'm now going to hand you over to Emma from the BMJ, who's also going to say a few words. Thank you.
Thank you so much, Elaine. On behalf of the BMJ, I'm delighted to say a few words about the World Health Organization World Bank BMJ collection, which is linked with the discussions in the sessions today. BMJ, as a journal and an organization, has a long history and interest in quality of care as a topic. And that's highlighted in the focus of this collection, as well as in other work that we do as an organisation. And that includes specialty journals that we run, such as BMJ Quality and Safety, and events that we organise together with IHI, the International Forum on Quality and Safety in Healthcare. This webinar today draws on that collection, with which we collaborated very closely with WHO and the World Bank. And I'd encourage attendees to look at some of the papers at bmj.com/quality of care. And these reflect an ongoing collaboration between the organisations. That collection has a series of articles together with other content which focus on the unfinished agenda and emerging priorities around quality of care. There are particular articles there, which I think some speakers will expand on and highlight today, which discuss the importance of continuous measurement for the purpose of improving care. And those highlight some of the challenges and also the opportunities in measuring quality and then using that data in change management. BMJ has been really proud to work with WHO and the World Bank on that collaboration, which continues because the aims of the project align with BMJ's mission of a healthier world and quality healthcare being fundamental to the right to health. So over to you, Blerta, to introduce more about what the webinar will cover today and introduce our speakers for the sessions.
Thank you very much, Emma. As you see, we are 3 organizations that are jointly working on quality of care. So first of all, why should we bother? Why should we think about discussing quality and especially measurement for quality? Next slide, please. Quality matters. We all know that quality matters. And in today's world, it matters even more. Access to healthcare per se doesn't mean health outcomes. Overall, the Lancet report on quality health systems identified that access to care means little if services are not delivered with quality in mind. Annually, 8.6 million deaths occur in 137 low and middle income countries due to poor quality care. Of this, due to a lack of access and poor quality of care. Of these, 5 million are people who sought care but received poor quality care. Next slide, please. In a broader language, and for WHO, the universal health coverage is the main goal that we are all trying to achieve by 2030 as part of Sustainable Developmental Goals, or SDGs. However, without quality, there is no UHC. Quality is not a given. It takes a vision, planning, investment, compassion, execution, and rigorous monitoring from the national level to the front line or to the smallest level, to make sure that quality is provided to everybody, everywhere, all the time. Those are the words of the WHO Director General, Dr. Tedros, which in a way frame why should we think about quality, but also the dimensions of quality and the types of measures that we need for quality. Next slide, please. To achieve quality, we need to think about different layers of decisions that start from the national quality policies and strategies and planning. For that type of thinking, we do need different type of data. We need data on governance, service delivery, financing, and all other health systems aspects that enable delivery of quality. However, quality per se happens at the point of care, where the provider meets the user, the client, the patient. And for that, we need very different types of data that allow us to understand if we are on track, if we are providing quality care, if that care is as per standards, but at the same time, if that care is facilitated at the point of delivery. And for that, we need a lot of facility assessments, provider surveys, quality improvement data that relate to improvement of practice, that links to case-based reviews and so on. But the point of care is not only about provision, it's about experience of care. It's about the patient and how the patient perceives that care, how it receives it, if that care is safe, and if it satisfies the needs at the time when those needs are there. So for that part of the equation in terms of quality, we do need different types of data. We need patient surveys and people's perception surveys. All this base or this wealth of information from a data perspective feeds at the different parts of the decision-making, of the thinking, starting from the national level to the point of care and service user communities. This kind of data is supported by additional data that comes from different data sources, from the ongoing health management information systems, data that is correctly and timely collected and used by through the records and reviews, through the national health accounts, and so on. Furthermore, we need support from qualitative and quantitative analytical reviews, And that all together needs to feed into the policy dialogue, into the quality improvement processes that can start from the front line, from the teams and the clinical level, from that engagement with patients and communities, and then trickling up at the organization, decision-making, management decision-making, and further up into the planning and policy making from a facility level to the national level. So with all this complexity in mind, what can we do and where do we start? Next slide, please. For today's discussion, we thought that we would start from where the care is provided, from the point of care. And we would like to discuss with all of you the challenges and opportunities that come through measuring to improve care. And with this, I'm very happy to hand it over to Dr. Kathleen Hill, Senior Principal Technical Advisor in Jhpiego, who is one of the champions of quality of care, quality improvement, not only for mothers and babies, that has been her career in the last 10 years, but also for all the health systems in general and health system strengthening. Kathleen, over to you.
Thank you very much, Blerta, for that kind introduction. And it's a pleasure to be with all of you today. Thank you for joining from wherever you are. Next slide, please. So as Blerta mentioned, I'll be focusing my presentation on measuring quality of care for the purpose of improving care and discussing some of the challenges and opportunities, particularly with a focus on the global south and settings that may be lower resourced in terms of information systems. Thank you. Next slide. So as mentioned by Blerta and also by Veitch, my comments today draw on the 2023 collection on quality of care that was co-led by WHO, the BMJ, and the World Bank, and includes 2 articles on measurement, which you may have seen. You are invited to review at your leisure. Next slide, please. So before we start talking about some of the challenges and opportunities related to measurement for the purpose of improving quality, I wanted to just take a step back and reflect on some of the common purposes for measuring quality of care. And of course, these are not exhaustive, but I think it's helpful when we're thinking about measurement and quality to very intentionally frame our thinking in terms of why we're measuring quality and for what purpose. So as you'll see here, there are potential differences that do affect the methods that we might use. For example, assessing quality of care at a single point in time, such as a healthcare facility assessment, Blerta mentioned this, to guide planning and track progress against country global targets, to continuously monitor quality of care, to guide real-time efforts to improve care, to periodically check whether quality of care is being maintained, and to periodically assess quality of care against standards for regulation and planning. Next slide, please. Duran's trilogy of quality management is a useful framework for conceptualizing some of these common purposes related to measuring quality. And many of you are probably familiar with this trilogy. Basically, the trilogy proposes 3 key pillars that are fundamental to holistic management of quality within any organization, institution, health system that can operate at multiple levels. And one relates to quality planning, to defining goals, developing policy strategy, and executing on those goals, including the priority measures and measurement systems to support those goals. The other relates to quality improvement. And for Duran, this is really about changing performance of a system from an existing level to a higher level. So this implies intentional change management. And we know that measurement is a core principle of supporting and guiding the effort to change performance to a higher level. Quality control is another pillar in the Duran trilogy, and this really relates to ensuring that performance of a system is maintained, remains stable over time. And then quality assurance is usually external assessment for the purpose of regulation, such as accreditation, licensing, etc. Next slide, please. So I think it can be useful to map the pillars of Duran's trilogy to common purposes for measuring quality of care. And here you'll see in the table on the left, the common purposes that I just reviewed in the previous slide and how they map to these different pillars within Duran's trilogy. And of course, this is, this is not definitive or completely covering all purposes for measurement, but I think it's a useful framework as we think about the different purposes and the different actors that need measurement for different purposes within a health system. Next slide, please. So in addition to different purposes for measuring quality of care, which domains are relevant to measure? And this is important because quality of care, as I'm sure all of us on this webinar will agree, it's complex conceptually and it is complex to measure. So in addition to the different purposes, I think many of us are familiar with these key domains of quality that were initially proposed by the Institute of Medicine in 2001 as part of their Crossing the Quality Chasm report. And then WHO has added one domain related to integrated healthcare. And these are now the domains that are supported by WHO as important domains when we think about improving quality and, of course, measuring quality. Next slide, please. So I think many on this webinar may be familiar with the Donabadian framework, which was first published in 1966 and remains an elegantly simple framework that many of us continue to use several decades later. And Donabadian classifies 3 types of quality of care measures, and these are relevant for all quality domains and all measurement purposes. One has to do with inputs. This is really the readiness of an institution or a health system to be able to provide quality, skilled workers, commodities, policies, finances, etc. And then the second category relates to the actual processes of care. What is actually done at the point of care at which people interact with a healthcare service delivery, and is that care competent? Is it people-centered? And here around care processes, the domains of quality that we talked about are an important category of assessing the quality of care processes. Is it effective? Is it patient-centered, people-centered? Is it efficient? Is it safe? And then outcomes, of course, are really a North Star for us in terms of assessing the quality of healthcare. For Donabadian, it is the combination of these inputs, these care processes and outcomes that allow us to paint a fuller picture of quality of care for multiple purposes. Next slide, please. So when we think about, as we begin to talk about some of the opportunities and challenges, particularly in lower resource settings, I wanted to briefly mention some of the key actors, users within a health system across the health system levels. And of course, this is not comprehensive. There are so many actors that use quality of care measurement, but this is really drawing from work that has been done as part of a network of countries working to improve quality of care for maternal, newborn child health. And we can think about, in terms of key actors, users, frontline health workers and their community counterparts. For example, members of a QI team within a healthcare facility, a hospital, a primary health center. And these actors really need to be able to continuously monitor a few quality measures to measure whether iterative changes to tackle underlying causes of poor quality are or are not improving care. Subnational health managers or a manager of a large hospital, for example, may need to regularly monitor a subset of quality measures across facilities to help them plan and manage subnational quality improvement and quality control efforts. And so they may not be directly improving quality of care at the point of care, but they are very, very essential in terms of providing the oversight and the managerial support and planning support to support large-scale quality improvement efforts. And then, of course, we have national program managers, policymakers, who periodically may track sentinel quality measures to guide policy strategy, program oversight, and track progress against targets, global and country. And then, of course, the very important stakeholders, which are the community and civil society. And, these actors are essential both for contributing to quality improvement and also for periodically reviewing measures to hold health systems accountable. For example, the use of community scorecards. Next slide, please. So now I'd like to just say a few words about some of the challenges and opportunities, and I'll be talking in particular in terms of health information systems, data sources and quality of data, health worker competencies, and then in the importance of inter-Qatar collaboration and coordination. Next slide, please. So to briefly talk about some of the challenges and opportunities related to data sources and quality, you'll see on the left here my attempt to characterize what is needed to support measurement for the purpose of improvement. And again, this is, focusing on one specific dimension, purpose of measurement. And we know that routine health information sources are a vital source of sustainable real-time quality of care data. That is the facility registers, the patient notes, national HMIS. And we also know that within health management information systems, different pieces contain different quality of care indicators. For example, not all data from a facility register is necessarily aggregated up into national HMIS. We know that periodic resource-intensive assessments, quality of care assessments and surveys, while they may be important for helping to inform the planning of quality improvement efforts, they're too infrequent to support quality improvement in real time. Longitudinal electronic records and registers can be transformative, but they're still not available in many of the settings that we're focusing on today. And our panelists, Dr. Reham and Dr. Sojiteti, will be talking more about some of these considerations. We also know that health workers are already overwhelmed with the documentation requirements that they have to shoulder. And so it's so important that we think about the judicious selection of really meaningful quality measures that are worth the effort to measure because they actually can support action. So challenges and opportunities in the settings that we're focused on today, we know that in many health management and routine health information systems, there is limited availability of standardized quality of care measures in RHIS, particularly for certain technical areas that have perhaps received less funding and government support. However, we do know from a number of surveys of quality of care of data elements within routine health information systems that we do see an increasing number of quality of care indicators now being incorporated into routine health information systems. We also have WHO recommendations about key content within technical areas to include in routine health information systems, which has also provided important guidance. Some quality domains are especially challenging to measure in routine health information systems in low and middle income countries. For example, experience of care, efficiency, timeliness, equity. There is growing experience with measuring some of these key domains, such as experience of care, safety, efficiency, equity. And actually, one of our panelists, Dr. Reham, will be talking a little bit about some of these domains such as equity, efficiency, to talk about the experience in Qatar. Next slide, please. So challenges and opportunities to increase health worker competencies and inter-Qatar collaboration. This is the other sort of bucket I would like to talk briefly about because it's so important for the purpose of measurement, for the purpose of improving care. So what is needed? We know that multiple actors need QI and quality of care measurement capabilities, and that different actors may need slightly different skills, competencies, depending on the context, technical area, and the, where they are working and supporting quality improvement efforts within an institution or within a health system. And some illustrative skills you'll see here, I won't read them out loud, but defining important, measurable, important, meaningful quality of care measures based on the improvement aims that are the focus of an improvement effort, monitoring and improving data quality. Dr. Soji will be giving more discussion about the importance of this, and analyzing patterns, for example, over time in a run chart. Common challenges and opportunities in the settings that we're focused on. We see that many countries are beginning to include QI skills strengthening as part of service supervision, in-service training, mentoring. But this is still, I would say, very much a work in progress. Although we're seeing a lot of change, we still really, in many settings, do not see the inclusion of QI skills strengthening as part of pre-service education and professional licensure requirements, and that this really remains an area of weakness, but holds promise. And we know that in some of the countries where there has been a very robust, journey over the last 20 years in higher resource settings, we now see that the incorporation of QI skills into pre-service education and into licensure requirements is much, much more present than it was 20 years ago. For example, when I trained as a doctor, we had nothing around QI skills building. Now, to recertify my boards, I have to actually demonstrate a QI project and demonstrate improved health outcomes for my patients. So this is really a change. And I think we're seeing this begin to come into the discussion more and more. And then I would also, I think another opportunity is that team-based QI skills building can promote stronger inter-Qatar health worker collaboration among key actors, health information officers, technical program managers, clinicians, facility managers. And sometimes we see that these people have historically operated in silos at all system levels, at the national, at the subnational, in healthcare facility institutions. And so we have, I think, an opportunity when we do more team-based skills building to really bring together these key actors so that they can all play their respective roles and coordinate and collaborate effectively. Final slide, please. So in conclusion, regular measurement is a core principle of improving care. We know it's complex. Selection and inclusion of meaningful quality of care measures in routine health information systems is vital. Finding the sweet spot of not too much and not too little measurement is not easy. It's a journey in progress. And we also know that we need additional approaches to measurement beyond routine health information systems to measure some of some quality domains that are very important, such as safety, experience of care, timeliness. And we know that health workers with skills, confidence, and motivation are vital. That regular measurement alone will not improve healthcare. Measurement must be coupled with actions to improve care. This is a key point. It could be a whole nother topic, but just always like to reinforce this. And then the importance of supporting inter-Qatar collaboration. So with that, I'd like to thank you for listening. And if I could have the next slide. The next slide, please. It is now my pleasure to introduce Dr. Jhpiego, who is the Vice President for Global Delivery within the Institute for Healthcare Improvement. And Dr. Jhpiego is provides strategic, technical, and operational leadership for Africa and the Middle East regions within the Institute for Healthcare Improvement. He is a public health physician, a trained quality improvement advisor, and a fellow of the International Society for Quality in Healthcare, as was mentioned earlier in this webinar. He led Ghana's Project 5 Alives project to national scale, scaling up high-impact interventions that reduced under 5 deaths by over 35%, across 200 public hospitals. And as mentioned previously, he is currently a member of the governing board of the International Society for Quality in Healthcare, based in Ireland, having been elected in 2020 as the first African to serve on ISQua's board. Warm welcome, and over to you, Dr. Jhpiego. I know that Dr. Jhpiego was having some internet connectivity issues. Can you hear us, please, Dr. Jhpiego?
Yes, I can hear you loud and clear, and I hope you can also hear me.
Yes, we hear you. Thank you.
Thank you very much for your warm introduction. Up until this point, we have heard about the global picture and movement to improve quality of care. And we thought that we would pitch this at the front line where everything happens, because as Kathleen said, measurement alone will not improve care, but definite actions. Next slide, please. So I thought I would focus on some country case studies and then look at what happens practically at the front line, and end with the very important subject of actions that can be taken to improve the quality and reliability of the data systems that we work with. Next slide, please. So we're sent into a country to do some work to improve maternal and newborn outcomes. So the overarching goal was to reduce neonatal mortality. So the month ends and we are waiting for the data to be sent in, only to realize that actually there is no register for collecting newborn deaths, and that the mortalities that are recorded are a mixture of neonatal and postneonatal mortalities. And so the entire project had to be sort of paused whilst we develop registers to be able to collect the newborn deaths. We also had to undertake training of the frontline health workers to define who actually is a neonate, because apparently it could not be taken for granted that we knew that the first 28 days of life was the life of a neonate. Another challenge that came across in this particular country was that at the very highest levels of the ministry, there was always an angry response when facilities reported high maternal or newborn deaths. And so this had created a pervasive culture of fear. And so people were afraid to even report. And the last thing that we observed here was that at the point when folks started reporting newborn deaths, upon further investigation, we thought the numbers were too low. The data was incomplete. It was upon further investigation we realized that they were only reporting case fatalities from asphyxia. This is a real health system. This is the reality that you come across when you hit the ground trying to improve the quality of care. Next slide, please. So what do we do when we actually get onto the ground? And many of you may be aware of this, but when the health workers at the front line define an area where they want to engage, we would tell them about the model for improvement. We would ask what we are trying to accomplish, which leads them to set ambitious goals. Would ask to know, how would we know that a change is an improvement? That leads to a series of measurements. Next slide, please. And then what change can we make that will result in improvement? And with a single change, we can plan a rapid cycle of improvement, because you want to test that change on a small scale, build confidence that it would work. And if it doesn't, the losses are not too heavy. You can abandon or adopt or alter the change or scale it up. So you'll be encouraged that you test on the small scale in this manner. But the point I want to make here is that once you teach, next slide, please. Once you teach the frontline workers this methodology, the key thing, as you go to the next slide, is that the point about your goal, what you are trying to measure, the point about how you would know the changes are improvement, all of them relate to measurement. So whether it's processes, whether it's outcomes, whether it's balancing measures, they all relate to measurement, which is that measurement is fundamental and key to the whole improvement journey. Next slide, please. Which then takes us also to the driver diagram. And this driver diagram says that what is your theory for what is leading to mortality in your facility or whichever area you're working in? Because once they have this model for moving their care processes forward, then they say, what is actually driving mortality? And if you can go to the next slide, and this slide is just giving you an example, and it has to do with reducing under 5 deaths, familiar topic. And we would say that there are 3 delays, and say that delay in taking the decision to come to the hospital, a delay in receiving care, and inadequate application of clinical guidelines and protocols. So these are the primary drivers. So we train the health workers at the front line that for each primary driver, we do need secondary drivers that impact the primary drivers. And we encourage each of them using the power of data to focus on the secondary driver that is most impactful on the primary driver. And then for each of those drivers, we come up with process measures. Now, here's a trick. If you can move to the next slide, please. The challenge that we then come across is that when you look at the overall aim, which is reducing under 5 deaths in whichever system you're working, often these outcome measures are tracked in your routine health system. So you would find it in your district health information management system or whatever system the health system is using. Then when you come to process measures, so for example, the average time of first encounter with hospital after onset of symptoms for a newborn. Now, this is a process measure that you are trying to use to measure delay in seeking care. And yet this process measure is not tracked in the routine health system. So invariably, people then have to put in place data systems for collecting some of these key process measures that ultimately impact the outcome of mortality that you are looking for. Next slide, please. So then you end up with a tension, what I call a strategic tension. Do you focus on the routine health system with all its data gaps and try to improve its reliability? Or as some do you want to create a parallel data system? And we've seen various partners working with national health systems adopt different approaches. I have some thoughts on that, which I'll share on the next slide. So then we talk about how do we actually use this data? Having established that data is critical to the improvement journey, how do we use it? And the point has been made. It is a critical helpmate to the improvement journey. And without it, you cannot see whether your changes are actually leading to improvement or not. And we've talked about the fear that grips some of the health systems when you're reporting the actual mortalities. So we encourage that people should use data for learning and not for judgment, which is that when mortalities are high, when adverse outcomes are reported, you want to continue to encourage the people to report the reality of the health system and to ask what are the systemic drivers of the numbers that you are seeing, as opposed to blaming individuals from what it is. The next point about learning from patterns in data is really powerful, in that you would go for many reviews at the sub-district level, at the district level, even regional level, and you would have people tell you that, oh, last year, 3 women died. This year, 2 women have died. There's a significant improvement. But if you track data over time, using your time series, using your run charts or your control charts with annotations, you would notice that actually your basic system has not changed. And you would be able to better tell which changes are driving which improvements. So the patterns are clearly very important. And we would always promote relying on the routine data systems. And we are not running away from the fact that there are gaps, but we would sooner support the national health system, the monitoring and evaluation units, to work on various aspects of data quality rather than to build a parallel data system, because ultimately that weakens the national data system. And when you finish your project or whatever it is that you're doing and you leave the national data systems weaker. So we would promote sustainability by relying on the routine data systems. But in addition, one must then work to improve the quality over time of the data as a parallel process to your improvement journey, and not take it for granted that the routine data system has reliable data. Next slide, please. So this is just to show some examples of what we mean by looking at data over time. The first run chart is looking at the percentage of emergency maternal and newborn referrals transported by a community-based emergency transport system. Here, there was an intentional effort to create community mobilization efforts for when a woman goes into labor so that there are no delays. And you would see that over time, we see how only 20% of women were being transported, and we end up with 76% of women being transported. Second control chart is focusing on postnatal care. How many newborns are being given postnatal care on day 1 and 2? Again, starting off with about 18% and ending at over 75% of newborns being seen on day 1 and 2. Using a variety of interventions, providing training to the health workers so that they can know what the guidelines and protocols are, linking them to midwives at lower levels so that even if they are discharged on day 2, there will be a home visit to ensure that they get the care. But by tracking the data over time and annotating with what specifically you have done, you're in a better position to scale it up, because now you know actually what works. Next slide, please. This one then focuses on data quality improvement. So I've made a point that we want to strengthen the routine data system. We want to work with it and we want to strengthen it. And this is where we need an intentional effort to improve the quality of care, even as the data quality, even as the QI teams need to work. So this is a picture from the sub-district level. And you know that we are looking, as an example, at ANC service delivery to clients at the sub-district level, so the health center. And you have a number of CHIPS zones. These are health posts that are reporting to the health center. You have ANC registered that are kept at the health center itself. And then you have ANC registers that they take out on community outreaches. So on ANC service delivery alone, you have 3 registers. And that then becomes a challenge for when you are tracking quality, because then your data could be incomplete depending on what you report at the DHMT. Next slide, please. And so here we identify the various points where you would have the weaknesses. From the source data, tracking all the way to the regional level, there are various points where you may face mishaps. Next slide, please. And these are various dimensions of quality, but for practical purposes, we would often focus on completeness, timeliness, and accuracy of the data as 3 dimensions to track. And in some of the work that we did, if you can go to the next slide, you would see how we use this to improve the quality of the data. So what are some of the strategies? Develop protocols for data quality improvement, not just within specific projects, but something that the National Monitoring and Evaluation Unit is rolling out across all partners for priority indicators. And then 2, creating a network of data health information officers. So whilst others are meeting to plan simulation, resuscitation, the data officers are also looking at completeness of the data and what PDSs can be tested at the front line to improve the quality of the data. Next slide, please. So this is an example of timeliness. The closer the point is to the red line, the more timely the submission, because many of the health systems have a target that within 5 days after the ensuing month, the report should be submitted at the district level. So this is a dashboard showing various districts and the timeliness of reporting. And so when you have that learning system, this is the type of data that you focus your interaction around. And we ask, so for the middle bottom one, they are very close, they are very timely. The question then becomes, what did you do to be able to improve your timeliness in this manner? And by sharing and learning from each other, you improve the quality of the data systems nationwide. Next slide, please. This also focuses on completeness. So again, training the data officers on the various data elements, and then also making sure that all the source registers are accounted for so that you track over time. And here you see the improvements from around 62% to over 100% completeness. In that circumstance, when we talk about a certain process or a certain outcome, we speak about it with confidence because we know that we have tracked completeness of the data systems. Next slide, please. And here is what a typical learning system for these data officers would look like. They would come with their own charts, they would sit together, they would analyze, they would share ideas, and would have deep conversations around various changes that have been tested and how those changes have actually improved the quality of the data system. Next slide, please. In conclusion, I would say that the efforts of frontline staff to improve care through quality improvement initiatives must be complemented by an intentional effort to improve the quality, reliability, and use of routine data that is often used to assess the effect of the changes tested. Thank you very much.
Thank you very much, Soji, for that very insightful presentation. Several of the topics that you've touched on are addressing questions that are coming through from participants. So thank you. It is now my pleasure to introduce our next speaker, our next presenter, who is Dr. Reham Hassan, who is the Assistant Executive Director of Quality Improvement at the Hamad Healthcare Quality Institute in Qatar. Dr. Reham, in her role, leads various improvement initiatives and work streams, including the National Value Improvement Collaborative, which she'll be commenting on, as well as other improvement efforts related to age-friendly care, patient flow. In addition, she contributes to education and training programs related to quality and patient safety at the university level and within the Hamad Medical Corporation. And she is also the lead of a national OPD improvement initiative. Her background is as a clinical hematologist. Dr. Reham has worked with the Hamad Medical Corporation for 2 decades, starting as a frontline physician when she helped to prepare for JCI accreditation and led numerous improvement projects. Dr. Reham will be sharing some reflections on her perspective working over, several decades in Qatar around some of the learning and implications for other countries that may be relevant. So thank you very much, Dr. Reham. We're very pleased to have you. I encourage participants, if you have questions, to enter them into the Q&A. We'll be addressing your questions after Dr. Reham's presentation. Over to you, Dr. Reham.
Thank you very much, Kathleen. I really appreciate the introduction. And I need to say thank you to all the panelists, including, of course, Dr. Sodji, for the invite to this webinar. On behalf of myself and my organization, Hamad Medical Corporation, and my institute, Hamad Healthcare Quality Institute. The institute was actually launched in 2015. It was a ministerial vision to support the Qatar changing healthcare landscape and the national focus on quality improvement and efficiency in order to deliver sustained changes. It might have been a way of answering to some of the challenges and the issues that we have been discussing over data management, but even the wider agenda of how to manage quality improvement in an organization was having an institute that was totally focused on quality improvement, building capacity and capability, and running national collaborative efforts in order to set the right tone in the organization. Next slide, please. So we had a way of looking at things from a strategic perspective, honestly, and the strengths and the achievements did not come all together from the beginning. We were building as we were flying. We had great faculty and support under the umbrella of a strategic partnership with the IHI. We could not see the end or the light at the end of the tunnel, but we were being led in baby steps, I might say, over a long decade of improvement. We had a high income system. We had the resources and the finance that we needed, but we had a long development journey also. The key factors is we had good resources. We had people and human beings who were believers and were trained by several entities, honestly speaking. It came as a strength, but it also came as a challenge because different ways of managing data or seeing or defining, we had to unify the methodologies and unify our data definitions to start with. How can we have unified KPIs for our system? The IHI partnership, as I stated, has been a key factor for success, and the fact that we're a small-scale system. When we say HMC, they're the sole secondary and tertiary provider in the organization. We do have 15 different hospitals and facilities under this same umbrella, but still it's a contained system, I have to confess. The fact that there is a brilliant point that was brought up by Dr. Blerta in her slide when she talked about the different levels from organization level, facility, surveys, and so on, and complemented by a healthcare system. And honestly, we started with what we had. We had a lot of facility data. We had a lot of accountability data because the JCI accreditation came before the awakening in the quality improvement part. So we were faced with a lot of data that was collected on quarterly or yearly even basis, which were not perfect to run improvement at microsystem level. They don't have the timely sense that Dr. Sodji was referring to early on. But we started with those. We started with bar charts and pie charts, which is not, again, typically what we need in improvement when we need to have data over time with run charts. But it was building up. And then we had to link with the national vision with the time. We had a healthcare system which is less than 15 years ago. So again, we were maturing even at the level of automating our data and how we can pull data from this healthcare system into for the use of quality improvement, and how to build platforms and automation, in addition to building the capacity and capability of people. This again has been a great strength in the system to date. Next slide, please. So we're showing you the end result, honestly, of, again, a long development journey. I might say the national collaboratives have been had a significant impact on shaping the whole strategic mandate for setting KPIs within a national healthcare system. Those different initiatives that ran as national collaboratives were able to define quality of care indicators and establish a standardized collection tools for systematic measuring of healthcare outcomes. We needed to ensure that the whole healthcare organization across the nation were aligning together their efforts in order to improve patient care and outcomes. Those collaboratives did identify key performance indicators and facilitated even informed decision-making, because they managed to go up to leadership and drive the continuous improvement effort by the right decisions coming up. And we had a series of collaboratives. We started with Best Care Always. It was a humble harm reduction. Again, back then, as I said, we were happy with whatever data we had. It was pretty much scattered. It was run at microsystem level, but it was a good learning. It was spreading the knowledge. Later on, the National Patient Safety Collaborative was a more mature collaborative. We focused on sepsis and VTE, so it had a good narrow scope. We managed to standardize data definitions so we could understand what is antibiotics, what is 0 hours, what do we mean by VTE prophylaxis, and when are we going to perform those, what are their, and we started collecting data over time. So we had run charts that were standardized between different units and different facilities. The slide that you have in front of you here right now is from the third collaborative, which is the National Value Improvement Collaborative. This is a far more mature methodology, again, by the IHI. And we were even mature as a team to go into this collaborative after 5 or 7 years of partnership. The beauty of it is that we had, at the start of the collaborative, what we call the linkage chart. This is not anymore units building their standardized KPIs, but they're also linking those measures and goals to the higher organizational goals and measures, which enabled the frontliners to become more strategic as they pick their projects and as they pick their indicators. Not only this, they were linking their outcomes, this reduction of device-related pressure ulcers or reduction of unnecessary investigations, to not only more than just a patient outcome or a patient experience, far more into enhancing efficiencies. They were calculating how much savings in a single unit it would be if they start focusing on any of those different measures, reducing their spending, but also how can they start scaling this across different units so that the hundreds of thousands of saving in one unit would multiply into millions of real saving in 10 units. And then imagine if you multiply this across the organization. Next, please. And this is, again, one more example of unnecessary x-rays. If we're looking at reducing harm by exposing the patient to radiation, but we're also linking this to the weekly cost of x-rays, and teams were frontline. Those are data from frontline teams, from nursing and physicians who are now not looking into their patient safety, again, linking it to efficiency and cost, and being able to reduce their own unit expenditures and accountable for it. Counting this by Qatari riyals and being able to report it up to leadership, showing them the power of quality improvement. Next, please. Far more mature collaborative was the Flow Collaborative. Now we're looking at building dashboards, okay, decision-making dashboards, not only from hospitals and frontliners, but we're involving also the business intelligence unit, coming up with good, rich definitions for each one of 12 different KPIs, and then building at the higher level that I think Kathleen was referring to when she talked about the patient experience and staff surveys and different surveys that might capture the person-centered part of the work, which we're again maturing as we understood the part about outcomes and process. We linked to value and cost, and now we're linking to the patient experience part in order to have a holistic indicators of improvement. Next, please. Hoping that we can come up with this dashboard of 12 different data or KPIs that we chose the different aspects of flow across the system that is being collected at hospital level, but linked also at strategic business intelligence unit level, owned by everyone, reporting back to leadership. And it has rich data over time that is even reflected as control charts, not only run charts. Next, please. Part of the strength and the one of the key successes or drivers for such initiatives would be building capacity and capability. We believe in the dosing approach, again, that was introduced to us by the IHI, and that we need to involve the frontliners, not only data analysts, but the ones who are giving the treatment and the proximal more to the patient care, the subject matter experts, who should become or should be given the opportunity to have profound knowledge in variation and data in order to give them full ownership of data management process. Again, as Kathleen said, key users and actors, building those and involving in training up to residents and fellows. And now we're even heading to students in Qatar University and Well Cornell in Qatar, planning for a clear program for students in medical cluster, multidisciplinary. And we've managed to have 34 improvement advisor in our organization, 29 improvement specialists. We have 10 graduates of a Masters of Public Health who are specialized in health systems improvement, and 5 IHI fellows. So those are all the expert level who are governing a full structure of training and building capacity and capability up from foundation up to the experts. Next, please. And this is nothing but showing you the different activities of training in order to have the fellows, advisors, and specialists that we're talking about who are leading the system from within right now. Next, please. So what more can we do on top? We need definitely to build more automation. There are some data that are flowing in smoothly, but we're hoping that we can automate the majority of the data in order to help our staff to maintain the timely reporting. The spread and scale up from every unit to another has been going beautifully, again, thanks to the national collaboratives, but sometimes we need to encourage this and get more or faster scale up. Honestly, the sustainability is an issue. Sometimes we do have diverse attention or changes in KPIs, of course, with the evolution of strategies and visions and so on. So sustaining and maintaining the data reporting and being resilient also on another part, it has been something that we're growing knowledge in, and building dashboards is an ultimate goal for us. We're doing this successfully with the flow and involving different business intelligence platforms. Thank you very much. And I think we're looking forward to any Q&A. Back to you, Kathleen.
Thank you very much, Dr. Reham, for that very insightful presentation, words of wisdom, experience. I think there's a lot of learning for all of us, and we appreciate your taking the time to join us today. So it is now my pleasure to moderate this question and answer session. And I thank you for all the questions that have been coming in through the Q&A as well as the chat. I am going to now share some of these questions, and Blerta Maliqi, Dr. Blerta, may be helping me as well, because there's a lot of feedback coming in in real time. So I think I want to make sure that I capture the full range of questions. I do want to mention that we will be many of the questions are being addressed as part of the Q&A, and I believe that we'll be compiling some of these responses. So I'd like to start, first I'd like to just say that many of you have noted the challenges related to poor quality of data, and that I think as someone said, yes, it's important to use routine health information systems, but if the quality of data is so poor, how can we trust it? I think Dr. Soji has provided a very practical illustration of ways to regularly monitor and improve quality of data. I think for the purposes of this, the Q&A, I'll go to some of the other questions because I think, although many of you have raised this, Dr. Soji did really address this question. There is a question from a colleague in Malaysia that also relates to several questions that have come through from others. Specifically, the statement is that QA/QI has been part of our healthcare systems for the past 3 decades, but it has always been seen as an additional burden by the players. How do we alleviate the perception of seeing measurement as a burden and a stick instead as a carrot in improving the system? I'd like to invite you, Dr. Soji, and also Dr. Reham, if you would just like to briefly offer some reflections on how we help health workers and managers to see measurement as something that helps them rather than is just an added burden. Thank you.
I think the use of measurement is at its core is an attempt to promote a shift in thinking and behavior. And we worked in many instances where when you start the improvement journey, the question is around inputs. Are you bringing more doctors, more midwives, more data officers? It takes time. I think that's the first thing. It takes time for people to understand that they have power at their level to make changes, and they have the data, and the data is not for a national officer. The data is for them to be able to use. And I think that happens when leaders stop being reactive to the data or to bad outcomes and to blaming people, but to fostering a nurturing environment where folks can discuss what they did to change things. And over time, you would see that the attitudes towards the data would change. In the initial work as well, I think that there was a lot of unnecessary fighting between QA advocates and QI advocates. I think increasingly we realize, as Kathleen pitched, you do need all of them. So for quality assurance, you will find the WHO driving for national quality policy and strategies. That's your plan. And then for the quality assurance bits, many countries have health facilities, regulatory agencies trying to implement basic minimum standards, which are equally critical. And then once you have those in place, what are the processes that we can improve and take performance to a different level? So constantly working with all of the 3 arms and shining light on the data to show whether the efforts actually yielded improvement. I think that's what ultimately changed the behaviors. Thank you.
Thank you very much, Dr. Soji. Dr. Reham, would you like to add anything?
I fully agree with Dr. Soji. I would actually summarize in 3 points, okay, from our humble experience in what would be, why would frontliners resist data collection? I'd focus on doctors since I have a bit of experience more with doctors, and why would they not share in the whole data management process? It starts in stages. The number 1 question, what's in it for me? You need to show them evidence, show them their own data and moving their own dots, okay? It might grab their attention. Start showing them some of their results and outcomes. And the next question would be, I've been reporting data, but no one has been really doing much with it, okay? There's no decision-making, there's no reaction, which is to the point of Dr. Soji. We need to be also preparing our leaders to react to whatever is coming up from the microsystems so that teams feel the value of their data collection. The third part, and you'd be really reaching a success or a breakthrough point if they start asking you, then how do I start really collecting and analyzing and building charts? Again, back to doctors, they don't feel confident if they're going to use a tool or a methodology that they are not experts on. This is again back to the part of building capacity and capability. You need to make people experts in whatever they're going to use as a methodology or a tool for data collection or a data visualization chart. If they master it, they're going to do a beautiful job and they were going to actually exceed your expectations, but they need to take the full ownership of it as frontliners.
Thank you so much. Very much appreciate that response and your reflections, Soji and Reham. So I'd like to now add another question that's coming up. And Blerta, please do feel free to jump in if you think there are topics coming up in the chat that I may not seen because I'm moderating. So one of the questions relates to for continuous monitoring of quality, we have to decide on the measures. There are so many, many sets of measures in the world. So I wonder, which one is suitable? Could you give some tips to select measures for QI beginners? So I'd like to just ask either of you to share your reflections. Thank you.
I think the driver diagram helps because at the end of the day, it helps you to scope your project. What area are you trying to improve? And what are the key processes? And the data relating to these key processes, are they in the routine system, or do you have to put in place a system to collect that data? And we would say about, I don't know, 3 to 6 indicators, not too many, but the most sensitive ones that speak to the most impactful processes. And then once you start and you record the improvement and you begin to see what the impact on the indicators with the changes that you're making, I think it gives you the confidence to be able to scale up your efforts. And also we would encourage that sometimes it's good to check within the routine data system, because I have interacted with a national data manager who says that the DHIS is also grossly underutilized. You know, he was saying that, yes, we can do run charts in the DHIS, but you guys never do it. You know, so sometimes there are some indicators that are rarely reported on, and what else, maybe that becomes the opportunity to activate those ones. But the fewer, the better, so that you can start instead of waiting to have a whole complex data system in place. Over.
Thank you very much, Soji. Anything you would like to add, Dr. Reham, or Blerta, or any of our other participants today, presenters?
I would like to agree with Dr. Soji when he suggested the driver diagram as a tool, and even for more advanced teams or systems, the linkage chart is an amazing tool for you to decide, again, about which measures link strategically so you can pick those critical few that Dr. Soji was highlighting, okay? There might be some things that come up on the driver diagram of a microsystem, but they're not a priority from strategic point of view, from ministry, from governing bodies, accrediting bodies. So linkage charts would help you pick those critical few that you need to start with right now in order not to dilute your energy.
Thank you very much. And there, on this topic, there are a couple of questions asking about resources and tools that can be used to help support measurement. And I do believe, and maybe Dr. Blerta would like to comment on this, that we are developing, WHO is helping to develop a toolkit, and also will be sharing, I think, a collation of tools, etc. Dr. Blerta, I don't know if you want to comment on this, because I think many people are interested in actual tools and indicators that may be available that they can use.
Yeah, thank you, Kathleen, and thank you for all the questions. I've tried to answer a few of those for which we do have active links and references to resources. So please refer to the chat as well. From a WHO perspective, the measurement of quality of care remains a priority. In fact, it is the main priority. Otherwise, how can we demonstrate results? Kathleen, she's the co-chair of the Quality of Care Life Course Measurement Working Group. So Kathleen, thank you for raising that point. We are intensively working in terms of developing tools, not only for measurement, but also for data quality and quality assessment. From a measurement perspective, the first, not the point of care, but at least the entry point for facility assessment, for facility quality information comes from facility assessments. In the introductory slide I used, you could see the different data sources that are attached to specific tools developed by WHO. We can share in the chat or post this meeting the links to those tools. Kathleen, if you allow me, I'd like to make a generic comment based on the different inputs that have come into the chat. Many of the participants are concerned, as you nicely summarized, from the challenge of what data, which data, too many data, what data sources, quality of data, and so on, in one hand. And then there is another line of questioning or inquiry in the chat and questions and answers that is raising the need for capacities, quality improvement capacities across all levels of systems, and asking a bottom line question, where do we start from? So all those questions are valid. From a WHO perspective, we are trying to address it from both ends, so top down and bottom up. Top down is basically creating the enabling environment that allows quality to happen and quality improvement to be institutionalized across all levels of care. That means attacking this issue from a perspective of policy strategy, so building the requirement for quality improvement to be there, as well as building the requirements for the capacities and competencies of health workforce to deal with data. So if the health workers are not able to use their data, or they are not motivated to use their data, or are not incentivized to use the data, then we are not going to advance too far in terms of improving the quality. Data use is the critical factor in improving the data quality that per se improves our decision making. So institutionalizing not only the data quality, but use of data for quality improvement is important, along with the skills that I'm not going to repeat the previous speakers, to use the data, to develop the charts and to make sense of it. So this is one aspect in terms of what we're trying to do from a policy and strategy, institutionalize and ensure the scaling up of capacities, competencies, but also systems that incentivize quality and quality improvement from both competencies and skills, but also from a data perspective. The second question that comes again around the use of data, how many data, I think Soji already answered that. It repeats across many comments. But the fact is that one has to prioritize those data that improve processes and then link that data with the outcome. So just improving processes for the sake of process without an outcome is not going to change the results. It may only increase the frustration of people who are trying to use data but don't see the result. So being able to trace, monitor, use the correct measures that do show outcome changes are important. Again, this links to the work that Kathleen and group are leading for together with WHO colleagues in terms of developing data tools and guidance. I'd like to go more in depth, but I think this is just a webinar. So perhaps this could be the subject of a follow-up webinar. So Kathleen, with this, I'd like to hand it over to you.
Thank you very much, Blerta, and thanks. We're very glad to have the leadership of WHO and ISQua and to be able to really draw on many of the useful tools. I think we're seeing lots of questions about this. I think we have time for one more question, and then it will be time to close this webinar. But there are a number of questions that are focused on a very important theme related to measuring person-centeredness and experience of care, as well as equity of quality. So, equity can relate to access, but of course also relates to disparities in quality of care for certain vulnerable populations. And this is a very, very important area. And another question also along these lines relates to, do we see room for clients of services to be able to contribute to measuring and monitoring quality of care as part of an ongoing process? So Soji and Dr. Reham, I'd like to just briefly invite you to share some brief reflections on this complex issue of person-centeredness, measuring person-centeredness of care and measuring equity, and any experience that you have that may be relevant for our speakers. Thank you.
Dr. Soji, would you like me to jump in? So for ours, from our side in HMC, again, we've been having a growing interest in patient experience. We have actually a full chief office right now for patient experience and person-centered care. For the sake of time, I focused on the National Value Improvement Flow Collaborative, but actually our newest collaborative a year back has been the Age-Friendly Collaborative, where we focused on a certain population, which is the vulnerable senior population, and how can we address their needs from a person-centered perspective. What matters to them, medication, mentation, and the mobility issues, which are very sensitive and a bit different when it comes to this population. It takes, again, involving the right subject matter experts, getting the leadership who are fully invested and engaged into the care of this population, and then running the conversation with them involving patients and families. So this is one of the collaboratives where we've had a patient and family advisory committee and a presentation from the patient and families coming in and looking into what are we measuring to ensure that the system is really capturing what matters to them really, and then involving even stakeholders from outside this group, from different disciplines or departments that are offering care for those populations. As you can imagine, they're not only served by geriatrics and rehabilitation, but they're served also by cardiologists and medicine and surgery. So how can we look at medication across all those entities? Okay, how can we respect mobility? It takes person-centered care, not only patients and families, but the person-centered from the staff involvement also, and taking their opinion into the KPIs and the measures that needs to be there. We invested no less than 6 months. Half of the time that we've spent on this collaborative was nothing but looking into the change package and change measures and seeing how much do they apply into our system and modeling those so that the staff feel comfortable with them and they are able to own them and sustain the measurement, and involving the patients to say, those are the things that are really capturing our needs and what matters to them. I hope this has an answer to some of those questions.
Thank you very much, Dr. Aham. Yes, and I think you've highlighted a wonderful example of an equity focused, as well as focusing on measuring and improving people's experience and the person-centeredness of care. As Dr. Blerta mentioned, WHO does lead a life course quality of care measurement working group, and one of the task teams in this group is specifically focused on measuring sort of what are the key domains and measures related to experience of care across the life course, person-centeredness of care, but also of providers' experience, because we know that's very important. And this task team is working to develop a sort of a compendium of resources and user examples, use case studies. So I think this is something that, we'll be very glad to hear from, to receive everyone's inputs on. I think Soji is back on. I would like to give Soji a chance to just, if he'd like to add anything. It's okay if you don't, Soji, because I know you had an internet connectivity issue, and then we'll be handing it over to Dr. Blerta to close this webinar with a few parting remarks. Dr. Soji, anything you'd like to add?
Nothing except warm thanks to WHO, ISQua, and your good self, and certainly Dr. Aham for joining us.
Thank you very much, Soji. Yes, I agree. We're very grateful to WHO and ISQua in collaboration with the BMJ Quality of Care Collection for organizing this webinar on a complex and really important topic that I know from all of your active engagement is a high priority for all of us. We look forward to continuing to learn together. We thank you for taking time out of your busy schedules to join us today. And I would now like to hand it over to you, Dr. Blerta, for closing remarks. Thank you.
Thank you very much, Kathleen. Thank you to all the panelists for this very interesting discussion. The chat now has come alive, and there are too many questions. We may need to have a part 2 of this session very soon. As we're moving forward, we just would like to share with you a few resources. We will continue to answer the questions after this webinar in order for everybody to try to have an answer. As we move forward, I would like to inform that this is part of a series of webinars that we are co-organizing with ISQua, but also with BMJ and other partners. So please watch the space for other announcements in the future. Thank you, everyone, and hope to see you in the next webinar. The link will be, the link of the webinar and resources will be available in the WHO and ISQua websites. Thank you.